So today what we're going to talk about is quality measures and really what it means for quality regarding organizations, particularly with our rural health clinics. Now, for all of those that are operating rural health clinics, again, this is not something that many of us have had to do from a regulatory perspective. Oftentimes, quality measures at rural health clinics is something that we select to do, something that we'll do as part of performance improvement, outcomes improvement, looking at all of those different areas. But again, it's not something that we've had to do and submit data similar to if we're a critical access hospital or running a long-term care facility where we have to submit this type of data. Now, when we talk through the information today, again, I'm going to do a brief overview of really where we've gotten to this current environment. After that, what I'm going to talk about is the change in the RHC reimbursement methodology. Now, you're probably asking, why am I going to talk about this as a part of the presentation? What we've seen in recent times is organizations that have really been successful have figured out a way to merge quality and finance to truly start to improve outcomes. We really have to start to break down some of those silos that have created an environment where finance is off doing something and quality is off doing something else. Next, what we'll do is get specifically into the quality measures. Now, I do want to thank LilyPad. They submitted a bunch of the data that we're going to use today as a part of the quality improvement and the quality measures. They've also submitted a bunch of data on the financial analysis. Myself, so I'm a former hospital CFO, COO at a critical access hospital, been doing this for the past 6.5 years on the consulting side, have done everything from hospital improvement, RHC, strategy, everything far between and in between. As we go through today, if there are questions, because we're going to be moving through various topics, please just interrupt me and ask the question as we're going through. I will also leave time at the end if there are questions, but I want to make sure that we can address anything that we're talking about today. I also promise that I will not keep you from lunch because I know I am the last presenter before the lunch hour. So first, overview. When we look at an RHC performance model, as I mentioned a moment ago, it's been very siloed, and I know this is hard to see up there for some of us, but nonetheless, it's broken down into ultimately trying to determine what is the value proposition for our rural communities. Whether we're a rural health clinic, whether we're a hospital, whether we're a large PPS organization, again, we overwhelmingly have to quantify and determine that value proposition for our clientele. Now, organizations that are able to do that often have improved financial incentives, improved outcomes, all of those different areas, because if you are a high quality performing organization, usually you will have more patients that want to come to your facility. Now, if I were to ask the group, and again, you can just shout these out, when we think of quality within a healthcare environment, whether it's hospitals or clinics, what are some of the different quality things that we think of from a public perspective? Or what are some of those that are freely known? Okay.
Ease of getting an appointment.
Ease of getting appointments. Okay. What else do we think?
Wait time.
Wait times. Now, when we look at all of those type of quality things, how much of that information can you find publicly? None of it. So when we look at that national level, again, we have those core measures, we have our HCAPs, we have all of these different things that are very much driven on the hospital side. And again, there's still those exclusions depending upon what type of organization you are, but not many of those carry over into the clinic side. Clinics have still trailed behind many of those other organizations relative to quality, performance improvement, and many of those different areas. I'm not saying that we're not doing it. I'm just saying that it's not regulatorily required and driven by some outside force to push those different areas. Now, when we look at the segmenting of the different information, we see all the way over on the left is strategy. Now, organizations will often create their strategy as to where they want to go and what they want to focus on. Then when we look at operations, it's broken down really between those two silos that I was talking about. You got your finance and you have your quality. If I were to ask the collective here again, how many of you have fully integrated your plans where quality is reliant on finances and finances is reliant on quality? Has anybody, one, raised their hand? Do the rest of us kind of evaluate it from finance is doing finance and quality is quality? And an example would that be like a rev cycle committee. Revenue cycle committee is doing one thing. On the other side, you have a quality committee that's doing those things. There's not really those linkages. And when we look at those different areas on the finance side, Because finance is much more analytical, there's a lot more information. We have our P&Ls, we have rev cycle, we have our rev detail reports, CPT codes. There is no shortage of information on the finance side on how we want to evaluate an organization and how we want to track performance improvement. Where it gets tricky is when we get into that quality side, because there's a lot more flexibility on the quality side to say, what do we want to focus on? How do we want to focus on these different areas? And what do we want to track to actually try to move the needle? Now, where did we get here and how have we gotten here? Now, when we talk about the siloing, and the reason why I'm talking about improvement models is because it's very easy to just talk about the quality metrics and to say, oh, we need to focus on these 5 things, and as long as we improve these things, everything's going to be great. If we want to truly change as an organization and move forward, we have to look at the linkages again between the finance and the quality and to come to merge those 2 things together. And what we've realized in current times is organizations that have been successful realize that finance has a direct impact on the ability to focus on quality. If you're struggling as an organization, if you're not performing financially well, you're not going to have the resources to maybe hire that additional case manager, or you're not going to have the resources to maybe get that additional technology to be able to do those certain things. Same thing on the quality side. In today's environment, quality outcomes is having more of a direct impact on the finances of an organization. You can look at things like PMPMs with commercial payers. You can look at all of these other things where they're starting to finance those. Now, when we look at the history of the evolution of improvement models, again, if we go back to the 80s, it was really quality improvement. And then on the finance side, it was really revenue cycle and finance. And there were really those 3 segments where they each focused on the different fundamental areas. That kind of continued all the way through 1990 to 2000, where it was really just a change in terminology. It went to quality improvement. In 2000 to 2015, as reimbursement models started to change and there started to be more organizational pressure, we saw a true merging of finance and revenue cycle, where they really came together and created all those linkages of focusing on those different areas. But nonetheless, quality improvement, which then moved to performance improvement, was still a separate silo. What we're seeing in today's times is the organizations that are able to really move the needle, move patient outcomes, and to move a client or a patient environment are the ones that have fully moved and integrated quality and finance into a single grouping. Now, this is not easy to do. These silos have been in existence for a long time, but it's something that we need to continue to look at going forward. So what I'm going to talk about today in the next area is, first I'm going to focus on finance. And what I'm going to talk about is, as everybody is aware, is the change in the RHC reimbursement model. I'm going to talk about that, laying the framework for how we need to start looking at quality in the future. Again, it would be easy to stand up here and just focus on for the next 30, 40 minutes on quality as a whole, but that would be ignoring the fact that finance will directly impact the ability to do these things going forward. So that's why I wanted to focus on that. What I'm also going to talk about is what the impact of the law means for the state of Virginia. Are we going to be net better or are we going to be net worse off? Again, not getting into the nuances of whether or not the law should or should not have passed, just what it means for the state as a whole. The reason for that is because as we talk about those different areas, it's going to drive how we can focus on different things. It's going to focus on us needing to increase visits, to increase our CCM, as was just presented on, do transitional care management, start to focus on all of those additional things that can drive revenue to our organization that get us a little bit away from 100% that straight fee-for-service methodology. Now, when we talk about the 5 characteristics of an improvement plan, again, I would say the one that we want to focus on today is using the data as a means to measure what we're doing. And I would say that that's probably the most overlooked area when we look at our organizations, particularly for rural health clinics. How many of us as rural health clinics are pulling or extrapolating data from our EHRs to do things like hotspotting for services, to do things to determine what type of services we should be expanding into, clinical outcomes for our patients? How many of us are leveraging all of that data to drive performance now? Couple? 3? Is it difficult to get that data out and manipulate it? One sometimes, one shaking their head no, one yes. And again, exactly, and what EHR you're on and whether they're interfaced and integrated. And that's what we're seeing in today's environment. What I would say as we look forward and as we start to look at these metrics, the data will be the most valuable resource that we have as organizations. It will drive where we want to focus on, it'll drive direction, it should drive strategy. And oftentimes there's many rural health clinics that will go in there that they're focused on either CPT codes or getting their patients seen. They never extract any of that data to drive decision processing going forward. And it's interesting, I'll tell you an example. I was recently at a clinic that was looking at saying, oh, we want to add another primary care provider. And when we were talking to them, we asked them, we were like, well, can the community support it? Have you guys looked at any of that? And they said, no, but we have somebody that just wants to come to our community. We want to hire them. And it's getting away from the if you build it, they will come approach, the field of dreams type methodology. Those days are long gone. And what we need to start looking at as we start evaluating our services, we can't only look at the services directly that we're providing, we also have to look at the services and the providers of other entities that are also in our service area. Because what often happens is we'll go into an organization, they'll say, oh, we want to add an orthopedic surgeon into our rural health clinic. And what they won't look at is the fact that down the road, a quarter mile away, you have a 27-person orthopod that's already doing all the orthopedic surgeries and all the cases. And you can't oftentimes support both within that same community. So again, start to think externally instead of just evaluating your services, and start to look more at what the services the community can support as a whole. I can't do a presentation without talking about finance. As a former CFO, it's just ingrained in my nature. So I have to talk about finances. Now, when we talk about the methodology, everybody's aware that on April 1st of last year, the RHC methodology changed. It really changed in a couple different ways. For our independent and our greater than 50-bed hospital-owned RHCs, the rate went from roughly an $87 upper payment limit and increased to what's going to be $190 in 2028 as an upper payment limit. For our provider-based RHCs that were owned and operated by hospitals with fewer than 50 beds, it went from a fully cost-based rate to now being subject to an upper payment limit. It also created a grandfathering provision. Now, the reason why I'm mentioning this again is because of the change in that methodology, it will change the approach that we start to focus on the delivery of care. In fact, a month ago, I was given a presentation and brought this up, and one of the hospitals said, but wait a minute, we're grandfathered, that doesn't apply to us. And I'm like, no, it does apply to you, it applies to everybody. So this is something that will fundamentally alter how we start to deliver care. Now, for our independents and our greater than 50 beds, the great thing about this law is, and the change in the reimbursement, you can start to expand and provide services that was maybe cost prohibitive before. Maybe you can bring in that case manager now. Maybe you can bring in that specialist under this new reimbursement methodology that wasn't otherwise available before. For our provider-based, we have to start looking at the fact that there is a cap in place now, and that we can't just spend freely like we did before. Now, on the original slide, these were all different colors. I realized they mostly look the same color. When we look at all of our RHCs, the one thing I want to emphasize again is all RHCs are now subject to some type of cap. The only question is what cap are you subject to? Now, for our independent RHCs, the only thing that changed for them is the rate has gone up. The methodology is exactly the same. It was upper payment limit before, it's upper payment limit now, just the rate is increasing to that $190. For our provider-based RHCs, again, it's broken down between 50 plus beds or fewer than 50 beds. For our 50 plus beds, again, methodology is exactly the same, just the rate changed. Really where the change came in is for our RHCs that were owned and operated by hospitals with fewer than 50 beds. And this is where you fall into a grandfathering provision versus a non-grandfathering provision. And this is also a true change in the methodology. So whereas the independence was a rate change, methodology the same, this is actually a methodology change where you're now subject to that upper payment limit. So not grandfathered in, any clinic that had not been an RHC by 12/31/20 or had filed your 855A to be an RHC by that date is considered not grandfathered. you are now subject to that same all-inclusive capped rate as the other clinics. No way around that. If you are a fewer than 50 beds and you were an RHC by 12/31/20 or had applied to be an RHC by that date, you can meet that grandfathering provision. And in that environment, again, your rate stays with you. You get that cost-based rate that is then trended forward on the MEI thereafter. One thing I want to emphasize, and whether you talk to me or any other consultant that works around the RHCs, those grandfathered RHC rates are very important. Think of it like a critical access hospital necessary provider. So long as you maintain that, you will always keep that grandfathered rate. If you were to change that or do something to jeopardize that, maybe you align it under a 51-bed hospital for a year, that rate goes away, you will never get it back. So it's very important that, if I can emphasize anything, establish an environment where you protect those things. You can also change the address, you can change ownership, you can do all these different things to maintain the rate. The key is maintain it under a fewer than 50-bed hospital. Now, if we look at the distribution of RHCs in Virginia, Virginia has actually seen a pretty significant growth in RHCs over the past 5 to 6 years. If we go back to 2015, there were 33 rural health clinics across the state. If we jump to 2020, it went up to 56. Now, what's interesting is we've seen a 250% increase in provider-based rural health clinics, and we've seen a 43% decline in independent rural health clinics. And actually, there's no non-provider-based RHCs or non-cost-based RHCs that are owned and operated by hospitals with 50-plus beds left in Virginia. So it's very much a distribution between fewer than 50 beds and independents. But nonetheless, this has shown that we've seen a considerable increase in the number of rural health clinics within the state. Now, next what I'm showing is the average cost per visit for all of the RHCs. So what we did to actually calculate this analysis is we pulled every single cost report from 2015 through 2020 for every independent, every provider-based, every greater than 50 bed. And what we want to do is calculate and see what are the actual costs per unit of service or the cost-based rates for those RHCs. We can see, as with every single state, they're all over the place. We have some that are low hundreds, we have some that jump up to $400 per visit. But nonetheless, if we look at a trend line, most of the clinics within Virginia have a cost-based rate that is less than $250 per visit. I've seen some states where the average is $350, I've seen some where it's $400 as an average. So it's great that we've done things to be able to control our cost here relative to those services. Now, when we also look at the cost per visit, it plays into the important factor when we were talking about that change in the methodology. So for our independents, if we look over here, those gray lines, those independents that had a cost-based rate of $175, $200, can you sustain services on $87 a visit? Exactly. So the independents were artificially lower or unnecessarily lower than what it should have been for decades. When we look at the other side, and again, we look at those provider-based with those rates all over the place, and again, not getting into political, whether I agree, disagree with the law, just stating what it is. If we have a clinic with a $400 RHC rate, is that sustainable for long term? If we keep increasing cost every year at 5%, I mean, can we sustain if the entire country were having $1,000 rates for RHCs? So both sides needed to be tweaked to protect the long-term solvency of the program. Now, because the law has changed, what do we do going forward? So as I mentioned a few moments ago, we pulled every single cost report for every RHC within the state of Virginia. And what we looked at was what was the average cost increase for our PBRHCs. Now, for the purposes of this, PBRHC are only those fewer than 50 beds. The non-PBRHCs are those that used to get the capped rate. What was the average or annualized cost increase for our PBRHCs versus our non-PBRHCs? So from 2015 through 2020, those non-PBRHCs saw an average cost increase of about 6.5%. The PBRHCs saw an average cost increase for about 4.5%. Now, realizing that change in the law of how it's playing forward, because all RHCs are subject to an MEI, the Medicare Economic Index, that we'll say is anywhere from 1.5% to 2% on average, if our cost is increasing 4.2% and we're capped at 1.5%, what does that mean for us as organizations? Any guesses? Money's going to be flowing through the doors. We're going to be... It creates a change in the environment where we have to start focusing on those other initiatives. Again, because our upside is capped, when we want to think about it as like a full at-risk ACO. You're limited to 1.5% increase, whether your cost goes up 20% or 4% or whatever, you're limited to 1.5%. So you have all upside, you have all the risk, but you have none of the gains. If you drop your rate to $175 from 200, you don't get the 200, you get 175. So again, you can get the benefit of improving, you don't get the upside risk. Now, when we look at this going forward, again, we trended forward all of those rates based on the 2020 cost report. And we said, for our provider-based RHCs that had an average of about $270, if we increase that every year by 4% and compared that to the Medicare Economic Index, what would we be losing in reimbursements in the future? By the time we get out to 2028, they're going to be losing on average about $76 per visit from Medicare and cost-based payers that are now applicable to this. For our independents that started at $87 in 2021, the upper payment limit is going to $100. So they're going to gain $12 per visit. Trending that all the way forward, again, we can see that this jumps up here. The reason for that is the average cost-based rate for those independents is less than the upper payment limit in those years, so you would get the lesser of the two. But nonetheless, by 2028, they're going to be gaining $87 per visit average for those rural health clinic visits. So beneficial on one side creates some exposure on the other side. What this table looks at here is this trends forward and says, okay, based on those increases, is Virginia going to be better off or worse off based on the distribution of clinics, the practices, the visits that are Medicare, and all of those different factors? Now, again, assuming the assumptions remain exactly the same, we would be worse off as a state. The state would lose about $2.6 million in reimbursements. This is not saying your financial position is going to decline. All this does is compare two methodologies from a numerical perspective. Now, what are ways that we can combat this? What are ways that we could try to turn this around? If I were to ask the group, what are some ways that we can drop our cost per unit of service in a rural health clinic? What are some things we can do to combat this? Increase volume. I'd like to say that's the easiest one. It's not, but that's the easiest one to think about. Exactly. If we can increase volume, because we have significant fixed cost and negligible variable cost in rural providers. Whether our provider sees 22 patients today or 16 patients, we still need a provider. We still need a facility. We're still paying rent, lease, and all of those different things. So increasing volume, exactly right. What are some other ways? Yes? Okay. Okay. Yep.
Yeah, make sure you're dropping the field for everything to do.
Okay. What?
The other one is, which right now I think Medicare is considering, which American Hospital Association has put a bill on their
Yep.
trying to push a bill for quality measures, value-based, that because they changed, this provider-based, they're limited.
Yep.
I think they are trying to say that if those provider-based clinics follow the quality measures and all those things, can they be uncapped again? So I don't know, maybe quality measures might be one of the issues which can be, help to,
Yep.
increase the rate or whatever.
Exactly. Another way is also how many of us schedule our annual wellness visits? How many make that as a practice that every single patient we're going to schedule them Not we're going to do it when they show up for some acute primary care service and we're just going to ask those additional, 7 questions and try to bill it. How many of us truly schedule those going out over the next year? Great. If you're not, I would say that's definitely something you want to add, because doing that in itself can help drive your visits. How many of us have reached out to commercial payers and tried to negotiate like a PMPM for doing certain type of performance improvement or quality? Okay, a couple. How many of us have looked at like PCMH, like Kate and others have been talking about? Again, all of these different things are opportunities to improve performance. Question or reaction? 340B for our provider-based rural health clinics owned and operated by hospitals that qualify. How many of us are doing 340B? How many of us don't like how the pharmaceutical companies are treating 340B right now?
What do you have to say about that?
I could talk 3 years on that.
About 5 minutes worth here.
Well, the original intent of the 340B program was to stretch scarce resources for rural communities. It was never meant as a rebate. It was never meant to be given back to the patient to defer the cost of medicine. It was really the federal government's way of saying, listen, healthcare cost is ballooning. Medicare can't continue to sustain the services and continue to subsidize the entire thing. So let's push the 340B program. Now, I disagree with the approach that the pharmaceutical companies right now are taking, which is really saying that they are only going to allow you to sign up one contract to retail pharmacy. Now, many of us that are running 340B programs, I assume we're doing contract to retail pharmacy, and that's what we're talking about. The biggest position right now that the pharmaceutical companies have been doing is saying, we're not going to allow you to sign up 7 or 8 different pharmacies for 340B. We're only going to allow you to do one. And this has drastically cut the amount of 340B services that is available to those hospitals. Now, HRSA has kind of gone in the other direction. Now, if you go back years ago, the interpretation of 340B was that it had to show up on your cost report, it had to be listed, and all of those different things. HRSA has actually taken a step back from that and said that if it is registered under the hospital, owned and operated under the hospital, you no longer have to wait for that cost report to be filed to do the initial registration to start getting that benefit. So HRSA is going in the direction of saying, let's expand 340B and allow more people to get it more quickly. The pharmaceutical companies are doing the opposite. They're saying, we're tired of paying for this and we're not going to do it anymore. Now, recent conversations are out that it's going to take some type of legislative change to hold the pharmaceutical companies' feet to the fire, or some type of lawsuit to get them to pay under the original intent. And I think because a lot of the 340B program was left to the latitude of the Secretary of HHS and all of HRSA and all that to kind of determine interpretation, that it wasn't a lot of things clearly defined in the federal law itself. I wish I could say it's easily going to change, but I think it's going to be a rough road ahead, because the pharmaceutical companies are the biggest lobbyists in Congress, by far more than any other entity out there.
Okay. Those are resistors.
Yeah, last numbers I heard, there was 2 lobbyists in Congress, 2 pharmaceutical lobbyists in Congress for every single congressperson. So they definitely spend money to try to do it. Now, the concerning part is when we look at the 340B program, what do you think the biggest cost to 340B is? Do you think it's the contract retail pharmacy programs, or do you think it's the hospital doing a major oncology program or infusions or things like that? When you look at the contract retail pharmacy program, it is a drop in the bucket compared to how much is spent on the hospital side. It's a fraction of it. But because most of the patients see the 340B and the lobbyists have played up the fact of, oh, you should be getting rebates from 340B, oh, you should be doing this, you should be doing that, that's where it's played into where the public is starting to question why they're not getting those rebates.
How can we make the 340B benefit our clinics?
Are you provider-based or independent?
Both.
So if it's an independent, you can't, because you won't even qualify. If you're provider-based, most of them are using that to sustain operations. They're using it to subsidize the differential between either the cost-based amount that they're getting from Medicare versus what it is for commercial. Yeah. They're using it to pad the bottom line. They're using it to, I've seen many that have actually been able to drive a ton of visits. actually leverage the 340B dollars to hire case managers, care planners, all of those different people to really go into a team-based care environment, a PCMH environment, and use that so that they can then say, oh, we're using this 340B money to actually improve outcomes, to drive, you know, those population-based initiatives, instead of just saying, oh, we're using it to keep the lights on. So it's also messaging. You can hire those people and say, listen, we want to improve outcomes. That's where we're using this money. But right now, the argument very much at that national level is, oh, it's just going to hospitals. Hospitals are greedy and don't want to share it with the patients, and that's where your 340B dollars are going. Yes?
But Jonathan, it's still, there are hospitals all over the country that are still acquiring brand new RHCs specifically for, they know they have a cap of 113 right now.
Yep.
But the 340B is still such a driver.
Correct.
Since we don't have the location issue of 35 miles.
Yep.
It's still becoming a very viable thing for hospitals to do, is to add RHC.
You're exactly right. The only concern is right now it's limited. They're only allowing you to register that one pharmacy. But Jeff is exactly right. And when we look at before the change in the law, if you were a 600-bed hospital, why would you have a rural health clinic? It isn't for the $87 rate. It's because you can push 20,000 patients through that clinic, and if your hospital qualified for 340B, that's a lot of money that can help subsidize care. So again, it's all those different nuances relative to that. Now, for a greater than 50 bed, I would also say that it's a greater strategy going forward if you qualify for 340B, because that rate's increasing to $190 as an upper payment limit. So when you compare an $87 rate to $190 in 2028, if your cost structure is greater than that, and you add 340B if you qualify, it changes the dynamic as to how we're going to start looking at competition in the industry also. Maybe before it wasn't worthwhile for large hospitals to set up a clinic in a rural community because $87 isn't worth it. Maybe down the road it is. So nobody will know what's going to happen in the industry as we continue to trend. If I did, I would run a hedge fund. I wouldn't be here right now talking about this stuff. Quality measures, and I think we have about 20 minutes left. So why is quality measure important? When we look at quality measurement, it's important because it's one of the ways, carving out the finance side, it's one of the ways that we can truly track the outcomes for our patients. And when we talk about patient outcomes, that is where the industry is going. If we look at where healthcare was, what do we think from all these different models, whether it's ACOs, or if we look at the Maryland model that's gone to budget-based, or we look at Pennsylvania that's gone to budget-based reimbursement, all of these initiatives are going towards population-based capitation type models. Now, I'm not going to get up here and say that within 5 years, the entire healthcare industry in the US is going to be population-based, fully capitated reimbursement. But what we need to do is start positioning ourselves for that changing environment. We have to integrate quality and have to start focusing on those things. If we were to switch, and I'll just ask the group, if we were to switch to a fully population-based model tomorrow, where we had to drive outcomes based on quality, how many of us would say that we're prepared for a capitated model? If anybody raised their hand, I would just tell you to leave because you're just not being truthful. There is nobody that's ready for a fully capitated model. Probably the farthest one along is Kaiser, and even they are still trying to figure out things, and they've been doing it for 30-something, 40 years in their insurance arm and business model. So it's putting ourselves in position to be successful going forward. It's realizing that as we start to look at these environments, again, low quality services, one, can lead to a loss of patients coming to our facility. Or if we have poor patient outcomes, it could also lead to patients needing more extreme services in a hospital or an emergency room. So again, it's taking that proactive role. That is why when we look at quality measurement, it's important because it lays the foundation for the health and wellness of our general population, the patients that are receiving services at our facility. It allows us to start to look at how we want to change and move the needle based on those specific factors. Now, when we look at the different ways of quality measurement, again, there's tons of different measures that we can jump into. We have our structural measures, we have our process measures. All of those are different ways that we can evaluate different things. What we need to look at as organizations is to determine what we really want to focus on from a quality measurement approach. We don't want to focus 100% on patient scores without paying attention to the structure. We don't want to focus 100% on performance improvement, focusing on structure and throughput and all those different areas, but then not measure the specific outcomes tied to our patients. So we need to focus on and select measures that span the full spectrum, because that's the only way that we can truly assess and start to pivot as the environment also changes. So again, don't stick with just one area. What I would also say when we're looking at measures and what we want to look at from the hierarchy of quality measurement is don't pick things that are so much at the 50,000-foot view. There's been often times where we'll go into an organization and they'll select a measure of, oh, we want to, the first one that comes to my mind is finance. I'm sorry, we want to improve AR, net days AR. Not realizing that there are literally 45 million different things that impact net AR. I mean, Patty could rattle off like 3,000 different things in probably the next 10 minutes. There are so many different things that impact AR. But we like to focus on those super 50,000-foot view things because they sound good. It's an area of focus. Oh, we dropped AR from 45 days to 41 days. Yeah, but how'd you do that? Was it your clean claim rate? Was it first pass? Was it conversion? Was it you finally integrated your EHR with the clearinghouse? I mean, what is it? And then they say, oh, we don't know. So pick those measures that allow you to focus on those different areas. Now, when we look at those different areas, it's good to select some very granular measures and some at those 50,000-foot view. And the reason for that is because that 50,000-foot view does provide a good snapshot of the state of the organization. But if we want to change and move the needle, we have to focus more on those granular things. That's when we're starting to look at those measures from that perspective. Now, the other ones is outcome measures and composite measures. Again, select some in each of those four-pronged areas. So what measure to choose? So we asked earlier, what are some measures that we are tracking? When we think from a perspective of healthcare, particularly our rural health clinics, what are some measures that maybe we should be tracking as organizations? Nobody wants to talk.
Are you talking about things like patient satisfaction?
You tell me. I mean, it's fair game. I have a laser pointer, so I can point at people too. Yes?
See, in all these, what I read, the one measure, in my opinion as a physician, is that the patient compliance. I don't see patient compliance anywhere. That should be really the measure to decide the quality, because if the patient is not compliant, no matter as a physician, whatever you tell them, give the medication, it's not going to work. Your measures are not going to improve unless the patient compliance is improved. So that should be actually the first quality measure instead of all this.
But how would we, so I would consider like patient compliance kind of at that top level, because there's so many things that can go into impacting patient compliance. Is it follow-up? Is it access? So how would we actually impact patient compliance?
That's what actually, because all those what you say in patient compliance, unless patient is convinced to take that medicine or follow the instructions,
Yep.
if they are not going to do that, no matter your measure of A1C could be less than 9.
Yep.
If 10 of your patients are not going to follow the compliance, your A1C is not going to come down regardless of what you do.
Unless you improve that one patient. No, it's a good point. What other measures could we potentially look at adding? What are things maybe that we're not tracking now at a clinic that we wish we were? Yes, Clarissa.
Does the patient understand how to administer their medication?
Okay. Is everybody ready for lunch? Okay. I'll move us along. Because people have that glazed look on their eyes.
If preventative services are up to date.
Okay, that's a great one. So I know that we have access. Is anybody using the Pond tool to track any of their data? Pond, LilyPad? Sorry, he has like 27 different names and acronyms. And John Gale has really done a great job of doing different analysis around the importance of quality and the tracking of different information. And as a part of the National Quality Forum, they've come up with, I think, 6 different metrics or 6 different things that we should be tracking from a quality approach. Now, that is built into the different LilyPad type tools. Now, I know that is available for everybody, but when we start to track that different information, it allows us to track those quality metrics in addition to a bunch of different finance metrics. So you'll notice the bridging theme of it has both finance and quality on the same report, so that you can track them in parallel with one another. Now, when we look at those different quality things, we got controlling blood pressure, preventative care, childhood immunization, diabetes, and current medications. Now, I agree with you wholeheartedly. There should be additional metrics and there should be additional things. One thing that's important to note is there's nothing at the federal level that requires us to present or provide any of this information yet. But we do have to get ahead of the needle. The reason why we're also focusing on this a little bit today is there has been a bill that's been introduced that does address the provider-based reimbursement. And it does say that in exchange for getting that uncapped cost-based rate, you would then be required to participate in, say, the PCMH program and submit certain quality data. Now, quality is going to come. I don't know how they would operationalize this. I have no clue. But nonetheless, when we start to look at the measures, are all of us at least tracking these 5 here? Is there any that you think we shouldn't be tracking? Or any that we'd swap out? Now, these are a bunch of other optional quality measures. Again, like I was saying, John Gale has done a ton of work on this, and if you just do a search for him, his email is in there. If you ever want to have a conversation with somebody that can talk to you for the next 27 years on quality, John can do that. He could also talk to you about behavioral health integration into an RHC and the importance of that. But these are other ones to focus on. The important thing that when we're thinking about is there is no one-size-fits-all approach. If you have a patient population that has, good in a certain score, switch to something else. Do constant changing so that you can continue to move the needle. One of the worst things we'll see for an organization is they keep the same things that they're evaluating every single year for the next 35 years. And then all of a sudden, our goal this year is we're going to increase hand hygiene in a hospital from 87% to 88%. Which when you think about it, it's kind of disgusting that 12% of the people don't wash their hands. But that's another conversation. But when you focus on those things, again, there's so many things to focus on. Don't just focus on the same things. You will never move the needle. You will never continue to show progress. If you achieve something, swap that out and swap something else in. Even if you're succeeding in the other one, it's good just to change the focus so that it removes some of the constant same old feeling all the time. It's my last slide, and then I will turn it over for the brief video before lunch. So the conclusions. The real important conclusions that I would say is, again, you have to merge the finance with the quality. We can no longer continue to do them independently. If you have a quality committee, it should have somebody from finance on it. If you have a finance revenue cycle committee, one of the funniest things I would see as going into a hospital is they would have a revenue cycle committee. And the biggest issue would be provider documentation. But then there was no provider on the committee. So they're not involved in the process. So again, merge those things together. Start to break down the silos so that you can start moving the needles going forward. Any questions?
What is the status of the bill which you said,
Going back to the uncapped?
Yeah, uncapped.
There's two bills that have been proposed right now. One is, it's a direct bill. It's in the House right now. It's introduced by Congresswoman Sewell out of Alabama, and that goes back to an uncapped cost-based rate for the submission of data. NRHA, the National Rural Hospital Association, they've also proposed or submitted their Save Rural Hospitals Act, and in there it also has language about going back to an uncapped rate. Now, not to say it's going to actually go back. There may be negotiations, as everything that happens in Congress. We'll see what happens going forward. But at least there has been conversation about it, but who knows what the outcome's going to be.
But this is for provider-based?
Provider-based, fewer than 50 beds.
Right. And so the other question is, the one that's requiring, basically is offering data submission as a trade-off for a higher rate, correct?
I mean, you can phrase it that way.
Well, that's in essence what it's, in other words, you know, they put this on there, say, is if you will raise the rate, we'll give you Medicare something for it.
Correct. We'll give you quality data in exchange for...
That you can use, that we can use in the industry to improve healthcare.
Correct.
But the other bill is basically sounds like a generic bill that's got new cap rates tucked into the middle as a rider.
No, the Save Rural Hospitals Act one, it is the difference between the two bills when they were originally drafted is that the one introduced in the House, every rural health clinic that was fewer than 50 beds would have to participate in the program and submit data.
Would have to.
The Save Rural Hospitals Act bill, it was elective. So you could choose...
So the data submission is in either bill?
The data submission's in both bills, but one required you to do it. The other one, you could submit the data in exchange for the rate.
I got you.
Yes?
Is there any correlation at all between how much quality FQHCs report and all the money they get?
Yes.
I mean, they tell the world how good they do it.
No, I mean, but that's, I mean, FQHCs get a 330 grant,
They get
and they get, you know, some of them get significant dollars.
Re-ask for questions. Is the nature of the quality out of FQHCs valuable?
Depends who you ask. Well, it depends on who you ask and who gets access to it.
It is to the government.
I mean, yes, to some levels. I mean, I haven't fully looked at the data. I haven't drilled into it enough. So I know people find value with the data, but whether or not it's driving the intended purpose, I just can't answer that.
Good rewrite.
So basically, you know, right now the rural health clinics are not required to go under MIPS and those things. And with this bill, if it passes, ultimately, basically, is it same as?
No, I mean, I still wouldn't see like all the
There be a different quality measures.
It'll be different. It would actually be up to the secretary to prescribe what specifically. The one thing that I identified in both bills is you had to participate in PCMH as one of the things, but then it also states the secretary of HHS would then determine what additional quality data would have to be submitted. It's not like when they passed the original RHC bill that they said, you have to provide these lab tests in this market, in this. It leaves everything up to admin. Great.